Hope you guys have enjoyed today's session so far. I'm sure this one will be as excited. Cool. All right. So still, I'm your host, Michael, and today's sessions are brought to you by Touro University's Doctor of Physical Therapy program and dual degree BS/MS of Occupational Therapy. With 2 accessible locations and expert faculty, you can become a sought-after licensed OT or PT in just 3 years done. For our speaker today, Dr. Peggy Compton, she is a professor at the University of Pennsylvania School of Nursing. Her area of expertise is the intersection of opioid addiction and pain, and her novel data have contributed to a growing body of literature on opioid-induced hyperalgesia, as well as informed guidelines for the management of pain in patients with addiction. Please let us welcome Dr. Compton.
Thank you, Michael, and I really appreciate being invited to speak with you all today about the work, about our program of research. Let me just go ahead and share my screen. There we go. All right. Yeah. So as Michael mentioned, I've been really interested in this kind of overlap or intersection between opioids, pain, and addiction. I'm sure you all know that opioids are our most potent analgesics out there to treat acute and severe pain. But opioids also have an abuse liability, and there are certain individuals who, when they utilize opiates for pain or for rewarding mechanisms, will actually develop an opioid use disorder. And that's really what we call, that's the diagnostic term for addiction, opioid use disorder. So when I talk about opioid addiction throughout this talk, the correct term that I'll be utilizing is opioid use disorder. All right, and what I hope to cover today is some of the neurobiological overlap between these systems that regulate addiction and pain. Then look specifically at the effects of opioid use disorder or opiate addiction on pain systems and get a little bit more into detail about this phenomenon of opioid-induced hyperalgesia. And then finally, I'm going to finish up with a few slides talking about how our tolerance for pain may actually be a predictor of our propensity for developing an opioid use disorder. As a review, some of you may be familiar with the neurocircuitry underlying addiction, but essentially there are 3 main systems that are involved. The first is the limbic portion of the basal ganglia, which provides reinforcement for all drugs of abuse. Sometimes you'll hear this neurocircuitry referred to as the reward center. So that if you're hungry and you eat, you stimulate reward. If you're thirsty and you drink water, you stimulate reward. That same reward system that drives functional behaviors is what gets stimulated with different drugs of abuse, that you get a rewarding or a reinforcing feeling from the use of those drugs. The second piece of the pathway is in the hippocampus, which we may know is where we lay down memory. And so associated with these highly rewarding experiences of using drugs and alcohol, we have strong memories associated with that reward. So we really remember that reward, and we remember it very strongly or robustly, such that it's difficult to erase or decrease those strong memories of reward. So you're clearly, by using a drug of abuse, not only getting reward, but linking strong memories to it, strong positive memories, reinforcing memories with it. And then that drives behavior. The prefrontal cortex is that part of the brain where we make decisions or choices about what we're going to do, how we're going to control our behavior. And so these highly rewarding memories will drive our behavior such that we will continue to use substances that provided that reward. But I like to think of pain and pleasure as existing on a continuum of human sensation. It's here. Yes, there we go. Okay. For pain is perhaps a violent pleasure. Who could determine the point where pleasure becomes pain and where pain is still a pleasure? Balzac wrote this back in the 18th century. And so already kind of a recognition in our literature that there was a relationship between pain and pleasure. Sharon wrote that pain and pleasure, though directly opposite, are contrived by nature as to be constant companions. It is a fact that the same motions and muscles of the face are employed for both laughing and crying. So again, this recognition that pain and pleasure exist on a continuum of human sensation. And this is just a very, very busy slide, just showing the neuroanatomy overlap between pain and addiction systems. So that there are many parts of the brain where both pain and pleasure are located, that they are co-located. So that's there's a lot of neurophysiological overlap between the systems that underlie pain and pleasure. And we know that opioids are important in these systems because when we administer an opioid antagonist, naloxone, which is more commonly known as Narcan, that's an opiate antagonist. It blocks the opiate receptors so that no opiate activity can occur. That when we administer naloxone, it activates, it blocks opioid effects in all of these different systems so that we understand that opioids do underlie that human continuum sensation of pleasure and pain. Opioids are involved in both of those. Now, we know that many drugs of abuse have analgesic properties. Opioids aren't the only ones. Many drugs of abuse recruit ascending and descending pain pathways to diminish the perception. Clearly, opioids, they're defined by their direct analgesic effects, but alcohol is anesthetic and analgesic at high doses, and it used to be that that's what was utilized when persons were experiencing acute pain, the alcohol would be utilized. Sedative hypnotics, especially the benzodiazepines, those treat painful muscle spasticity secondary to upper motor neuron damage, and they're standard adjuncts for procedural sedation and analgesia. They're commonly co-administered with opioids to provide sedation and analgesia. Certain central nervous system stimulants, such as cocaine and caffeine, those also produce and potentiate analgesia by increasing activity in descending inhibitory pain pathways. And then cannabinoids. We're learning a lot more about the fact that there is some good preclinical evidence that there's an independent THC-responsive anti-nociceptive pathway, particularly effective for pain of neuropathic origin. So all these different drugs of abuse do carry with them some analgesic properties. And notably, all these drugs of abuse provide reward, as we saw in the previous slide with the reward center, via activation of the subcortical opioid systems. And notably, withdrawal from all of these different types of drugs of abuse and alcohol increase the perception of pain. So people, when they're going through withdrawal, regardless of what drug they've been using, when they're undergoing withdrawal, they are more sensitive to pain. Now, I want to focus more specifically on opioid use and opioid use disorder and pain. If we're treating somebody who has opioid use disorder for their pain, it's complicated because the drug that they abuse is also the analgesic that we're providing. So clinically, it can become difficult to manage the pain of people who are hospitalized who also have an opioid use disorder because we so commonly use opioids to treat pain. And we can talk more about that in the Q&A session if people are interested. But we have to remember that individuals with opioid use disorder, I'm abbreviating it here, OUD, they may seek the psychoactive effects of the drugs, but they're not immune to the effects of these drugs on central and peripheral opioid-relevant pain systems. As we saw before, these areas are overlap, and so therefore, if you're using opioids to get high, you are also activating or having an effect on pain systems. In some cases, pain may be the original impetus for opioid exposure, so that people may not have ever experienced an opioid unless they have pain. And early research in both human and animal models indicate that opioids are less rewarding in the presence of pain. So for a long time, we thought that if you had pain, that would protect you against the more addictive qualities of opioids. And there is still evidence for that, but we have to be careful because a subgroup of patients treated with opioids for pain do meet diagnostic criteria for OUD, opioid use disorder. So the presence of pain cannot be considered a sufficiently protective factor against reward to occur. So reward seems somewhat diminished if opioids are administered in the presence of pain, but pain does not protect people from developing opioid use disorder. I'm going to be now covering some slides, some of the original data that we developed looking at pain and pain responses in persons with opioid use disorder. And I just show this slide to show you the pain assay that we typically use in these studies. This is a cold-pressor test, which is essentially a glorified bucket of ice water that we ask people to put their hand in. When the cold sensation becomes painful, we call that pain threshold. And when the person needs to take their hand out of the water because they can't tolerate it any longer, that's called pain tolerance. And so we use this very widespread, frequently used pain assay to measure pain responses in patients who are who have opioid use disorder. And so this is some initial work that we did using this cold-pressor test, and we were comparing people who were currently using opioids, people who are currently using cocaine, and comparing those to people who were no longer using opioids and no longer using cocaine. And so the larger bars here mean they were able to keep their hand in the water longer. So you can see that the ex-cocaine abusers were able to keep their hand in the water longer, for the longest amount of time, and you can see the people who are currently using opioids could keep their hand in the water for the least amount of time. So they were most sensitive to pain. And probably the first thing you'll notice is that the people who are no longer using their drugs of abuse were able to keep their hand in the water longer. So they were better able to tolerate the pain. And this could be for reasons. We do know that just having the disease of addiction, the disease of a substance use disorder, it does result in a syndrome of what's called pain facilitation. And so their discomfort may be augmented by subtle withdrawal symptoms. As I mentioned previously, anytime anyone's going through withdrawal, they're more sensitive to pain. There could be some intoxication or withdrawal-related sympathetic arousal and muscular tension. Frequently, people who are active in their disease have concomitant health problems. And we do know that anybody with pain, who suffers from substance use disorder will have disturbances to their sleep, disturbances to mood, functional changes, increased interpersonal stressors. And we know for patients without addiction who just have chronic pain that sleep disturbances, affective changes, functional changes, and interpersonal stressors all lead to increased sensitivity to pain. The pain feels worse because of that. So there's several factors that go along with having a use disorder that would in fact facilitate pain or make pain feel worse. But what was interesting to us was the fact that the people who were on opioids, so these were people typically taking fairly large doses of opioids every day. Most of these patients in this study here were in a methadone maintenance program, meaning they were taking a full opiate agonist between 70 milligrams to 120 milligrams per day. And yet they were the ones who could tolerate the pain, the cold-pressor pain the least. They were the most sensitive to pain. And that's kind of counterintuitive because, as I mentioned from the outset, we tend to give opioids to treat pain and bring the pain sensation down. But in fact, people who were taking these large doses of opioids every day were the least tolerant of this cold-pressor pain. We continued this work to compare people on methadone maintenance to normal, healthy control persons. And you can see in this first figure here that people who were taking methadone were much less likely, much more pain sensitive to the cold-pressor pain than control persons were. And this second figure here is comparing people on methadone to people on buprenorphine, which is another medication we use to treat opioid use disorder. Sometimes you'll hear it referred to as Suboxone. It's different from methadone in that it's a partial opiate agonist. It's not a full opiate agonist. But you can see when you compare those groups of people with opioid use disorder taking either methadone or Suboxone, that they tolerate the ice bath, again, for much shorter period of time than do the matched normal controls. In additional work, we showed that this didn't matter whether or not they were at their peak or trough methadone blood levels. Either way, they were less sensitive. They were less able to tolerate the cold-pressor pain than normal controls. And this bottom figure here, we followed people who were using heroin and looked at their cold-pressor tolerance prior to coming into treatment. And again, you can see the people who got into methadone treatment or buprenorphine treatment tolerated the pain, tolerated the cold-pressor for a much shorter period of time than matched normal controls. And as we followed those patients on methadone or buprenorphine over the course of their treatment, we really didn't see an improvement or a change in their ability to tolerate the cold ice bath. So even getting people into treatment or putting on a different opioid, moving from heroin to methadone or heroin to buprenorphine, did not really have a change in their ability to tolerate the ice bath. So what was going on here? We knew from the animal literature that there is a type of hyperalgesia, meaning you're more sensitive to pain than you normally would be, related to the use of opioids, and that's called opioid-induced hyperalgesia. And essentially, it's defined as increased sensitivity to pain resulting from opioid administration. And so it's been demonstrated for years in animal models that if you take a pain-free animal model and you make them tolerant to morphine, they have a significantly decreased tolerance for pain. So opioids, in addition to providing analgesia, also set into motion anti-analgesic or hyperalgesic processes, hyperalgesia. And when we see people going through opioid withdrawal and they're hyperalgesic, they're more sensitive to pain, could it be that we are unmasking that underlying opioid-induced hyperalgesic state? And could it also play a role in analgesic tolerance? With the fact that people who take opioids over time to treat their pain, they may need higher and higher doses of opioids to manage the same pain, known as tolerance. Could it be that people aren't so much becoming tolerant to the opioids, but they're becoming hyperalgesic? And for that reason, we need to increase the amount of opioids that are given over time. Now, opioid-induced hyperalgesia has been conceptualized as an opponent process, such that we're trying to maintain homeostasis by an opponent process, but actually we end up in a new allostatic state. If we look at this figure here, you can see we start out with kind of a baseline pain tolerance. If you administer opioids, the first thing you're going to see is opioid-induced analgesia. So people will get an analgesic effect from the opioids. But counteracting that analgesia is the opioid-induced hyperalgesia, so that it's counteracting the analgesia, and that will increase over time to a point where their pain tolerance is now less than it used to be. And it's thought that these opponent processes are important because even though you're taking opioids, it's still important as a human being that you can experience pain. So just because you're taking opioids, you still need to know if you stubbed your toe or you're touching a hot lamp or something that could cause pain. So it's believed that this hyperalgesic process is functional in that it allows you to continue to perceive pain even in the presence of opioids. But what happens over time is that those hyperalgesic processes predominate, and the tolerance that you had prior to taking opioids is now lower because of these hyperalgesic processes. And interesting to me was that when I was reading more about it, I found that it wasn't necessarily a new observation. Clifford Albert wrote in 1870, "At such times, I have certainly felt it a great responsibility to say that pain, which I know is an evil, is less injurious than morphia," and that was the name for morphine addiction back then, "which may be an evil. Here, experience is needed. Does morphia tend to encourage the very pain it pretends to relieve?" Charles Carter wrote, "He, speaking of the morphine addict, is also affected by a hypersensitiveness to pain or a morbid tolerance of any kind of distress. He suffers. His suffering is actually great. To his astigmatic inner eye, it seems even greater than it is." So there was an early recognition of this opioid-induced hyperalgesia phenomena as we were beginning to use opioids more commonly in the treatment of pain. So as I mentioned, a lot is known about opioid-induced hyperalgesia from the preclinical models, from the animal models. And basically, I'm summarizing in this slide what we know about opioid-induced hyperalgesia in preclinical models. That these animals who have been made tolerant to morphine have a reduction in their baseline pain thresholds, that this hyperalgesia is noted across different types of painful stimuli. So whether it's thermal, chemical, electrical, any kind of nociceptive or painful stimuli will be affected. It's demonstrated across different opioids. So whether we're administering heroin or fentanyl or morphine, we see the same in animals, you see the same hyperalgesia occurring. It's demonstrated across route of administration. So it doesn't matter how you're giving the opioids, animals will still develop the hyperalgesia. It is dose dependent. So the higher doses and the more cumulative exposure, the more severe the hyperalgesia. It increases around wounds, incisional wounds. So if you're doing surgery on an animal that has had opioids prior to surgery, they have more hyperalgesia or more pain tenderness around the incision site. The resolution of hyperalgesia in animals is similar to the time course of its development. So if it's developed rapidly, you can reverse it rapidly, and vice versa. If it takes a long time to come on, it will take a long time to offset. It is intensified with antagonist-precipitated withdrawal. So if you give animals opioids and then put them into with naloxone or Narcan, you'll see an increased hyperalgesia. And the more times an animal goes through withdrawal, the more severe their hyperalgesia appears. It's been demonstrated to be most robust in female animals, and we're not quite sure why, but it does share some of the mechanisms. It does share some of the mechanisms that underlie the development of neuropathic pain, which is a type of chronic pain that is due to change in the nervous system. So that people who, some of the same molecular changes that occur with opioid-induced hyperalgesia are the same types of molecular changes that occur with the development of neuropathic pain. So what do we know about, that's the preclinical literature. What do we know about opioid-induced hyperalgesia in humans and clinical populations? I've already shared with you the work that we've done looking at how it affects people who are on medications for opioid use disorder, methadone or buprenorphine. So I've already presented that work, but I now spend a couple slides talking about what we see with respect to opioid-induced hyperalgesia in healthy volunteers who are administered opioids acutely and then undergo pain testing, in patients who are administered opioids during the surgical period. So that's a surgery. The intraoperative period is time when opioids are often administered. And then also looking at patients who have chronic pain and are taking opioids on a regular basis. Do we see hyperalgesia occurring in those patients of chronic pain who are taking opioids regularly? So first, with respect to healthy volunteers, these are data that we collected on normal healthy college students who had an opioid exposure in the past, but they were not opioid dependent. They did not have an opioid use disorder, but they hadn't been exposed to an opioid. So we weren't giving it to them for the first time. And across 4 different sessions, they received either a dose of intramuscular morphine, a dose of intravenous morphine, a dose of intravenous hydromorphone, which is a more potent opioid, or placebo. We were all double blind to what they were receiving, even though the patients could tell if they got something active or not, but our data collection was double blind, so we didn't know what they received. Then 5 minutes after they received once they were at the peak effects time for the different medications, the different opioid that we gave them, we would then administer Narcan or naloxone, that opiate antagonist. So we were essentially putting people into opioid withdrawal. And you can see changes in their ability to tolerate the Cold-pressor test. With placebo, the purple bar here, they barely had any difference at all. If you hadn't given them an opioid, they received placebo, and then you gave them Narcan, there was no effect on pain systems. But you can see that if they had received a single dose of IM morphine, IV morphine, we gave them a shot of naloxone, we were able to precipitate withdrawal, and they were less able to tolerate the Cold-pressor test. So these are changes from baseline. So even in these normal, healthy people without an opioid use disorder, a single dose of an opioid on a day, putting them into withdrawal, we could see changes in their ability to tolerate pain, and they appeared to become hyperalgesic. With respect to the intraoperative setting and opioids, where opioids are commonly administered and opioid-induced hyperalgesia, there have been some good studies done that show that the higher potency intraoperative opioids, things like fentanyl and remifentanil, they do have post-operatively, they have higher pain scores at rest than patients who received less potent opioids. The pain scores were the higher pain scores were most pronounced early in the post-operative period, up to the first day, post-operative day. And it was most reliably observed with high-dose remifentanil. That's a very, very potent opioid, and high doses of it resulted in higher pain scores at rest following surgery. These patients also who received high-potency intraoperative opioids, they used more post-op morphine following surgery. They needed more opioid to manage their pain. They had significantly decreased pain thresholds. Their wounds were more tender, but there weren't any other opioid adverse events. So they didn't demonstrate more respiratory depression or more constipation. The changes that we were seeing based on the use of these high potency opioids intraoperatively were limited to pain related phenomena. Their pain scores were higher, they used more morphine, and their wounds were more tender. This interesting proposition, you may or may not know that depending on the type of surgery, it's not uncommon that for certain percentages of patients that their acute postoperative pain never goes away. It turns into chronic pain, that they continue to have pain, that their acute pain turns into chronic pain. It doesn't go away entirely. And this is known as the chronification of surgical pain. And it depends on surgery, as I mentioned, but across different types of surgery, up to 10% of patients, their acute postoperative pain never entirely resolves and it becomes a chronic pain. So they're living with that chronic pain for the rest of their lives. And it appears that there may be a role that opioid-induced hyperalgesia plays in this chronification of surgical pain. This first little figure here is just comparing it's called surface allodynia. So basically it's the amount of tenderness, if a non-painful stimulus is applied to the skin or to the area around the wound. Patients, as you can see from this figure, that received high doses of intraoperative opioids, they have a greater amount of wound hyperalgesia. Their wound is more tender than patients who received lower doses of opioid during surgery. And there's some interesting data that this amount of hyperalgesia, how tender their wounds are, is associated with the development of persistent pain, chronic pain, 6 to 9 months after surgery. So you can see that these patients in the bigger figure here, it's a little hard to read, and I apologize for that, but the triangles represent patients, upside down triangles represent patients who received low doses of opioids in the operating room, whereas the little crosses represent patients who received higher doses of opioids in the operating room. And when you look at 6 months and 9 months after surgery, you can see that the people who still have pain are more likely to be the people who had the little crosses, the people who received higher doses of opioids. So we can see that in the intraoperative setting, higher doses and more potent opioids result not only in a more severe postoperative pain, but it's the patients that receive those higher doses that are more likely to also develop chronic pain. Their acute pain never totally clears up, and they develop a chronic pain syndrome. And finally, talking about patients who have chronic pain who take opioids on a regular basis, do we see opioid-induced hyperalgesia occurring in those patients? There are a few prospective studies out there because it's difficult to find patients who've never been on opioids, who have chronic pain, who've never been on opioids, and then we administer opioids. I'm sure you are all familiar with our understanding of the current opioid crisis and how it did initiate because we had so many patients with chronic pain taking opioids on a regular basis. We do know that as the opioid dose increases, and this is over studies, if you're more than 100 milligrams of morphine equivalent dose, morphine equivalent, so any opioid that we give, we can convert to a morphine equivalent dose. As that opioid dose increases, we do see an increase in opioid-induced hyperalgesia. We're more likely to see opioid-induced hyperalgesia in the presence of chronic neuropathic pain, which is that type of pain that I mentioned previously that is related to changes in the nervous system. And it could be for those patients with neuropathic pain, it may actually be accounting for the fact that they're more sensitive to pain. So we can't quite tease out in patients with neuropathic pain, are they hyperalgesic because they're taking opioids, or are they hyperalgesic because they have this type of pain known as neuropathic pain? So it could be a mix of both, making it more difficult to study in those patients. This is a small study that looked at patients with chronic pain and looked at how intense the intensity of their heat pain, how intense did they rate the pain administered via thermal stimulus, heat, before and after 4 weeks of hydromorphone therapy. And you can see that in the patients who received the hydromorphone therapy, which is opioid therapy, 4 weeks following administration of it, they did rate the pain as more severe. So in this small study, there was evidence that patients with chronic pain who receive opioids on a regular basis will have an increased perception of the pain severity. The control group here were people who did not receive any opioid. And so you can see there's no change in their ability to tolerate pain. But what you can also see in the population of chronic pain patients is that their perception of pain was already higher than controls even before they received the opioids. So again, there may have been a neuropathic component to their pain. This is another small study, but it looked at patients who have chronic pain who on a regular basis needed to undergo a lidocaine injection. And so they just looked at a standard lidocaine injection in these chronic pain patients. And they found that the higher the opioid dose that patients were on, if they were taking larger doses of opioids for their chronic pain, that their pain scores were higher, that they rated the pain as more unpleasant associated with the lidocaine injection, and they had more pain behaviors around that lidocaine injection. So the higher dose of opioid that patients were on for the treatment of their chronic pain, the more painful they found a stimulus, clinical stimulus, which was a lidocaine injection. Study that we did looking at patients who were about to undergo dental surgery. They were going to have some teeth extracted, and we were comparing their post-operative pain responses between those who came in on chronic opioid therapy and those that did not. And you can see that with this first figure here, that even before the surgery, patients who were on opioids prior to surgery rated the cold-pressor pain as more severe and also rated heat pain as more severe. When we followed them after surgery, again, you can see that the people who were on opioids prior to surgery rated their pain severity as greater than patients who were not on opioids. And finally, when we looked at the number of analgesic doses taken postoperatively, these patients were all prescribed as strong nonsteroidal, kind of a very strong Motrin for the treatment of their pain. The patients who were taking opioids prior to surgery also needed more doses of analgesic to manage their pain. And this is another study looking at if, in fact, patients with chronic pain, when they're taking their opioids, are hyperalgesic, what happens if we taper them off of their opioids? Do they have ability to tolerate pain better? And you can see from these figures here that people who underwent a taper over time, they rated the interference of pain as less, the pain life as much as did prior to the taper. And they also rated themselves as having more pain self-efficacy. They felt like they were better able to manage their pain following an opioid taper. And this is a very small study that we did, kind of looking at the same thing. This first figure here is showing you that over time, we helped patients taper their opioid doses, not down to zero necessarily, but we did taper their doses over time. And we could see with these patients, now it's too small of a sample to look for statistical significance or anything like that, but you can see that over time, their ability to tolerate the cold-pressor pain improved. So they were better able, for the most part, most of them were better able to tolerate the cold-pressor after an opioid taper as opposed to prior to an opioid taper. I want to point out, though, in both of these, this slide and the slide before it, where we talked about an opioid taper, in no cases were we tapering patients down to zero. We were just decreasing the amount of opioid they were exposed to. But there is this kind of counterintuitive finding that kind of goes against what I'm showing here, what I've shown you thus far. These were patients who had opioid use disorder, who underwent a 28-day opioid detoxification. So they were very quickly tapered off of their opioids. And you can see with respect to pain latency or pain threshold, pain tolerance, and their how intense they rated the pain, it didn't change much from baseline between baseline and 28 days out. That their pain threshold remained relatively stable, their tolerance for pain remained relatively stable, and the severity, how intense they rated the pain, stayed relatively stable over the course of the detoxification. We didn't see an improvement here, which leads me to think about, could it be that people up as being having opioid use disorder, are they hyperalgesic by nature? This figure here is showing what we know about the Cold-pressor test, that a bucket of ice water in normal, in just the normative data. And we can see that it's a bimodal distribution. About 1/3 of the normative data are rated relatively pain intolerant. They don't tolerate it well, whereas 2/3 of the normative population are very pain tolerant. They can tolerate the ice bath for up to 5 minutes. And so by nature, it appears some of us are born more pain intolerant, some of us are born more pain tolerant. Could it be that the people who are born more pain intolerant are the ones who are likely to find opioids most rewarding and therefore develop opioid use disorder? This is borne out in some of the animal literature. Again, if you look at different strains of mice, there are certain strains of mice, the bulb Cs here and the CXBHs, they have very high pain tolerance. They also get a great analgesic response when you give them an opioid. They get a really good, robust analgesic response. But however, they don't find opioids very reinforcing or very rewarding. Often you have to hide it in their food in order to get these animals to become opioid tolerant. And they also do not have a tendency to develop opioid-induced hyperalgesia, these different strains of mice. However, if we look at the C57s and the CXBKs, they look just the opposite. They have poor pain tolerance to begin with. They don't get a great analgesic response when you give them an opioid, but they do find opioids highly rewarding and reinforcing. They will self-administer opioids readily, and they're also more likely to develop opioid-induced hyperalgesia. So could it be that the patients I'm seeing in the methadone clinic are actually more like the C57s or the CXBKs? They're kind of born pain intolerant and find opioids highly rewarding. And so all I'm doing in looking at their pain responses is unmasking this strain of individual. I mean, there's some other data to kind of support this idea that people with people who are pain sensitive more likely to find opioids rewarding or reinforcing. These data are looking at the propensity of patients to develop opioid use disorder using this what's called the SOAP, the Screener and Opioid Assessment for Patients in Pain. It's a tool that assesses the risk for developing a substance use disorder in patients who have pain. So we looked at their scores on this risk tool and compared that to their pain ratings. And this was using a punctate mechanical stimulus. So we're just kind of pushing like a little pin into them to see how they rate the pain. And these chronic, they're not on opioids, on low dose or on high dose opioids. And you can see, hopefully, oops, sorry about that. Here. That patients who had a higher score on the opioid use disorder scale, risk scale, were more likely to feel the pain is more severe. So again, we have patients here who look to be at risk for developing an opioid use disorder, rating pain as more severe. This pain assay, this punctate mechanical stimulus, rated it as more severe, regardless of whether they were taking opioids or not. And we also looked at this in following chronic pain patients who did develop an opioid use disorder over time. So these were patients with chronic pain who developed, after administering them opioids and giving them opioids for the treatment of that pain, they did develop opioid use disorder. This is an assay sensitization, which is basically a wind-up of the central nervous system. And you can see again, that patients with opioid use disorder had more of this wind-up phenomenon over the course of the painful stimuli being administered, as opposed to patients who did not have opioid use disorder. They kind of got used to the stimulus over time, whereas with patients with opioid use disorder, they didn't get used to the stimulus. They actually perceived more pain over time. So again, we're seeing this hanging together of patients who find opioids rewarding and are also pain intolerant. So the hanging together of these two phenomena. So therefore, could your pain tolerance, your baseline pain tolerance, serve as a way to predict whether or not you'll find opioids highly rewarding to the degree that you develop opioid-induced hyperalgesia? So I will just summarize now that there is overlap between the neural systems underlying pain and addiction. We saw that in a number of slides. That the presence of addiction complicates the experience and management of pain. That opioid addiction specifically may complicate pain management due to opioid-induced hyperalgesia. And that poor pain tolerance is associated with the development of opioid addiction. So I thank you for your attention, and I'm happy to stop sharing.
Yeah, thank you so much, Dr. Compton, for such an amazing presentation. For me personally, I had never delved so much deep into the field of addiction and pain, honestly, and that was really mind-blowing for me. And yeah, let's just dive into Q&A questions then. So there's an attendee that was asking, given that cannabis have a similar function as opioids, are there any concerns for cannabinoids at potential hyperalgesia when it comes to states legalizing medical cannabis for qualifying conditions, symptoms such as chronic pain?
That's a great question. We don't know the answer to that. For so long we weren't allowed to study cannabis that we haven't really gotten into it. I would hypothesize that if a person's experienced cannabis withdrawal, they're going to feel more severe pain. The pain will be more sensitive. But we haven't had any evidence to describe cannabis-induced hyperalgesia.
Right.
Great question.
Yeah. And then actually there's a question that's earlier in the chat that was asking like, why is extra certification required to prescribe buprenorphine but not opioids? And will that change basically?
It's another great question. For those of you who don't know, that to give methadone, you have to be in a specific methadone. Required extra training to be able to give morphine or Suboxone to people with opioid use disorder. And that's been a barrier to providing that medication, very effective medication to patients who could benefit from it. And so they've become more lax with the need for training. They've allowed now nurse practitioners and other health professionals, not just physicians, to be able to take that training. But it looks like we're moving towards a place where that training will no longer be required, and that people, when they apply for a DEA license to prescribe opioids, they'll get a little training along with that DEA licensure around opioid prescription and opioid-induced hyperalgesia and addiction. They'll get some training around it, but it won't be a specific training that's required. But it's a great question because it has been a barrier to us getting buprenorphine or Suboxone to people who could benefit from it.
Great. Okay. Yeah, that pretty much concludes our today's session in interest of time. But yeah, thank you so much, Dr. Compton, for such an amazing presentation and such an insightful Q&A session. And we do really appreciate you speaking at our conference again. And
thank you.
Yeah, of course. And for everyone else in the room, we'll transition to our next session on A Career Path to Neurosurgery by Dr. Theodore Shores. And yeah, basically see you in the other rooms soon, but let's applaud real hard virtually to Dr. Compton.